Okay, we are live. Welcome to Ortho TV. Over to you, John, sir.
Okay, good evening again. And now we have a series of webinars which are going to be based on some of the clinical examinations, and as the practical exams for the DNB have been fixed for March. I think it's really important that they go through the clinical examinations. We don't know whether this time they'll have full sort of standard practicals or a combination of OSCE and dummy cases, etc. But whatever it is, I think the importance of clinical examination cannot be sort of relegated to a second place, and it's really essential that the candidates would know how to examine each joint in a proper way. And so we have again Professor Ananda Kishor Pal from Kolkata.
Thank
You want
you.
to give us this talk. Welcome to you, Professor Paul.
Okay. Good evening, everybody. So thank you very much, Professor Jan Mukhopadhaya and the Oref for giving me the opportunity to discuss with a very important topic, which is not only important for the examination purpose also, but also for the patient care also. And now there is very right time to discuss, as the question pattern of DNB has become changed especially the practical examination from the completely physical examination to some part is going to become the OSCE examination. So my talk will be very much basic about it. So this is the message. I think Dr. John Mukhopadhaya and everybody to convey for the students, all students. We should be very much basic about all the techniques, and because these especially that for the DNB students. So as the OSCE, for it is be extremely formative and extremely there are some extremely basic questions it is given, and that is to be answered in a specific time and in a specific manner. So without any wasting of time, I'm going to share my screen. So that is the examination of hip, which is a very relevant topic for this. So all of you know, is it visible? Is it visible? Is my slide is visible?
Yes,
Okay,
sir, visible.
okay. So all of you know, just for a few basic things, that is the basic things of the history taking is that basically we have to know the purpose, which is basically purpose of the history taking.
Ananda, you need to put it on full screen. Sorry, it's
okay.
That's good.
So basic purpose of taking the history is basically the categorization of the disease. There are different diseases can happen in the for the hip joint. So most important, we have to categorization, like it may be traumatic, like the malunited or non-united intracapsular neck femur fracture, or it may be some diseases like the infective diseases, like the tubercular arthritis of the hip. We have to give some specific diagnosis of this. So we have to categorize this disease with the help of the history. And next is the protocol. I'm not going into detail. There's basically a history of chief complaints, followed by the history of present illness, past illness, and the past personal illness, family history, and for the immunization history for the child, as also for the menstrual history for the female. So I'm not going into detail, and this is the basic structure. So just I'm going to highlight these 7 specific questions, 7 S questions. So this is if the specific S questions, it is asked for the even in a very busy orthopedic bed OPD scenario, you can easily categorize the disease. Suppose this is the first S is the sex or age. Next is the starting of the disease. Starting means it may be acute disease or it may be chronic disease. So there is a traumatic disease, always it is acute disease. Suppose there is an infective, there is a tubercular infection, it is always a chronic disease. So we have to just after asking the probable diagnosis, next question will be what will be the points in favor of your diagnosis. So you have to start from the history, then the examination, then the investigation. So from the history of to start, this is a chronic indolent course. So it's a monoarthritis. So this is the first point for the tubercular arthritis, like that. Next is the site and site. It may be the single site, may be multiple site. There is symptoms. It may be only the local symptoms, or it may be systemic symptoms. like the loss of appetite, significant loss of weight, like that. So some grave diseases like the malignant diseases or the chronic, suppose chronic debilitating diseases like tubercular arthritis may be associated with some systemic illness. But other suppose traumatic, the intercapsular neck femur fracture, there is no systemic illness. So this is so after the chief complaints, the next point is the history of present illness. So the basic type of the basic body of the history of present illness is these. There are three components. First component is the chief elaboration of the chief complaints. Next is the important positive history in favor of your diagnosis, and the important negative history to rule out the other diagnosis. So in that case, these 7S questions will help you to categorize. And lastly, the last part is the cardinal symptoms. So the three component of the history of present illness is first the elaboration of the chief complaints. Next is the important positive history in favor of your diagnosis, and important negative history to rule out the other diagnosis. And lastly, the cardinal symptoms. And next is the past history, significant past history, and the personal history. So these are the symptoms. So next is the span, duration. So duration may be very short, it may be long. If suppose it is a rheumatoid arthritis, there will be a there is long duration. It may present for last 3 to 4 years, and there is a progress. Maybe there is some spread is maybe there is sporadicity. There is another S is sporadicity, that is intermittent symptoms followed by symptomless period. Intermittent symptoms followed by symptomless period. There is waxing and waning of symptoms. So that is a long duration of the course with waxing and waning of symptoms. Polyarthritis, or maybe morning stiffness. These are the basic criteria for the inflammatory arthropathy. So these are the diseases as given on the right side. So it's by 7S question can easily categorize the disease from the history. Spread with the progress of the disease. Some disease is progressive, some disease is non-progressive. Progressive, that is it is ascertained by with the due course of the time. There is a gradual deterioration of the symptoms, there is a gradual restriction of the activity of the daily living, or there's a gradual reduction of the walking distance. So these are the 3 points. There is a gradual reduction of the walking distance, gradual restriction of the activities of the daily living, and gradual deterioration of the symptoms. These 3 points can easily diagnose that disease is progressive, as like tubercular arthritis is a progressive disease, or malignant diseases is a progressive disease, whereas it is a traumatic disease. Suppose it is a non-union, so it is not a progressive disease. Suppose it is a benign tumor, it is not a progressive disease. So these are the sign of progress, history of progress. And the severity is most important. The systemic feature or the cardinal symptoms, as I mentioned, this is the last part of the history of present illness. Cardinal symptoms, what are those? Cardinal symptoms basically there is a significant loss of weight. There is 10%, more than 10% loss of weight in last 3 months, or the patient will complain of gradual that the short is become very much loose. Or there is a significant loss of appetite, there is bladder bowel problems, and also there is sleep disturbance. So these 5 features: significant loss of weight, loss of appetite, bladder, bowel, and the sleep. These are the 5 cardinal features. These cardinal symptoms, if these are positive, these indicate is a sinister significance that may be related with some grave diseases like malignant disease, or it may be due to spreading infection, spreading pyogenic infection, or there is a chronic tubercular infection. So this is the 7S symptoms by which you can easily categorize the diseases. Next, this is the pain. This is the most important. We have to categorize the pain. So pain may be mechanical pain, it may be inflammatory pain, or it may be infective or neoplastic pain. There are 2 points. One is the aggravating factor and the relieving factor. So if there's a mechanical pain, it is always aggravated with the activity, it is relieved by rest. Whereas the inflammatory is just opposite. So pain may occur during the rest. That is why the patient with inflammatory arthropathy is complaining of pain at the end of the night. Once they get up from the sleep, patient will complain of severe pain. Even in the last part of the sleep is become disturbed during changing their position inside the bed. So it is very difficult to sleep in the last part of the night. So it is always occurs in the rest, but it is relieved by activity. Because in the rest, there are inflammatory materials accumulate during the activity, it is dispersed. So this is the pain, rest pain relieved by activity is the character of the inflammatory pain, just opposite to mechanical. Whereas the infective and the neoplastic, pain is present always. So there is no relieving factor unless the patient takes some medicines. Otherwise, there is no relieving factor. But there is always pain, and the activity can aggravate. But there is no relieving factor. So by this aggravating factor and relieving factor, we can easily categorize the disease. This is maybe mechanical disease, it may be inflammatory arthropathy, or it may be infective or neoplastic. Again, I'm already told, I'm not going to repeat. The symptoms of progress is there's deterioration of symptoms, activity of daily living, and the gradual reduction of the walking distance. The past history, if you suspect that avascular necrosis of the femoral head, so the past history, there was significant trauma other than this episode, maybe maybe 4 years back, maybe 3 years back, like that. No significant childhood problem. So this is most important. So no childhood problem like the prolonged incapacitation, fever for weeks, rule out the infection, pain in other joints, throughout the inflammatory arthropathy, bleeding diathesis, multiple deformity, there is a Gaucher's disease. Because these are the relevant history may be related with the avascular necrosis of the human. So these are the positive history you have to take. Or there is no history suggestive of surgical intervention other this episode. Like this, if there is a history of surgical intervention for the intracapsular neck femur, that can lead to avascular necrosis. So that history should be taken. Or there is a history of drug intake, which may be related with some avascular necrosis, like steroid and radiation therapy. So these are the relevant past history. Now, personal histories is A, B, C, D, E, F. This is most important. A for the allergy, alcoholism, the addiction. B for the birth trauma, bleeding disorder. C for the contact, like contact with tuberculosis. D for the drug intake or the addiction. And E for the environment is most important, environment. And F is the family history, and O for the occupation. So now we are coming to the exact orthopedic examination, that is the hip examination. As you can, in all general protocol, we have to take the consent of the patient, and we have to take the position, we have to make the ideal position of the patient, and also the sequence, we are going to sequence. And the consent is most important, that we have to, before touching the patient or talking to the patient, we have to make a rapport to the patient, so that our examination protocol will become very easier. So, and this is the exact tips for the students. This is the exam kit bag. What are the structure? What are the points? We have to keep it in your bag for the adequate examination. These are the usual. What is this? These are the basically there are some notebooks. Because in notebooks, if there is a physical case, you have to write it down some salient features you may forget, so that you can assimilate during after that. And this is also very important for the male. It is most important, otherwise it can be very difficult. So if you offer this, so that you can make a easy rapport to the patient, he will cooperate. Otherwise these are for the basically for the child. So we are going directly to the orthopedic examination. It is a life has become easier because there are 7 broad heading. So we have to remember the 7 word, that is 7 broad heading for the hip orthopedic examination: inspection, palpation, movement, measurement, special test, examination of the proximal joint and the distal joint, neurological, vascular, and the reticuloendothelial system, the last point. Every point has been divided into 3 subheading. Like inspection, it may be the inspection, it may be divided into attitude deformity. Next is the swelling or wasting and the skin abnormality. But for the lower limb, it is most important, we have to see the gait examination. So how to get examined? What are the prerequisites? Prerequisites, it should be, patient should be barefooted walking. Basically we are going the non-instrumental of the observational hip analysis, observational gait analysis. So we have to instruct the patient to walk barefooted. They walk in a straight line and walk as far as possible, as fast as possible is most important. So first important point is this: it may be stable gait, it may be antalgic gait, or short limb gait, or it may be unstable gait. And just I'm going to show a picture. Just I'm going to show a picture. Yes. See this picture. This is basically, it is a, what is that? It is a Trendelbach gate. As how can you see the Trendelbach gate? As you can see here, is it visible? Is it visible?
No, sir.
Okay. You're gonna have to share your screen again, I think.
Okay. Just. Is it visible now? Is it visible?
No, sir, not yet.
Okay. It's not visible? Just a minute.
Your screen is not shared. You need to share your
Okay.
screen again.
Okay.
Green arrow at the bottom.
Okay, I'm just going. Okay. Is it visible now? Hello? Is it
Yes, sir.
visible? Is it visible?
Picture.
Yeah, your thing is visible, but now you need to run the video.
Yes. Yes. Can you see that? Yes. Hello?
Yeah,
Is
the
it-
video is not moving yet. Yeah.
Is it not moving?
No. Just seeing the list of videos there.
Yes. But it is not moving.
Now double click on one of them, whichever one you want to do.
Yes. Is it moving?
No, is it playing on your screen?
Okay, yeah, it is playing. It is playing.
So maybe you need to share screen again, come out and then try it again.
Okay, I'm share it. See,
Yes.
now?
Coming back to that, all the videos as a list. Sure.
Okay, it is not visible, no?
So what I would suggest is you switch it on.
Okay.
Switch it on, minimize it, and then screen share. So
Okay.
Yeah.
That can be done. Okay. Okay, that can be done.
And then play it from the bottom.
Okay.
Dr. Pal, what you can do is that you can share screen जब आप करते हैं ना, उसमें आप पहला वाला ऑप्शन सेलेक्ट कीजिए which is screen और उसके ऊपर डबल क्लिक कीजिए. The first option.
Yeah.
Then you will be able to see the whole screen. Then whatever videos you want to play, you can play.
Okay. Just a minute. No, पहला वाला स्क्रीन जो है ना, पहला वाला ये वाला.
The first one you have to select. The first
So
one.
you go to share screen and then select the first one. Yeah?
First one, double click that.
Okay.
Yeah, good.
Is it visible?
Yes.
Yeah.
This again only the video is seen, not everything.
Okay. Is the video is seen, na?
Yes.
Okay. So this is the Trendelenburg gate. As why it is Trendelenburg gate, you can see here. So you have to see the rhythm of the lower limb as also the trunk. As that, see the trunk. This trunk. His trunk is going, so swaying of the trunk side to side like the clock. There's a wall clock. As the wall clock is moving, the stand, this podium of the wall clock is moving like the side by side. Similarly, the trunk is also going side by side as it is the swaying of the body on the affected side as the left side is affected. So this is a Trendelenburg gait. So this is a Trendelenburg gait. Okay. Now, if it is a short-limb gait, so if it is short-limb gait, then we have to see the.
No, again, nothing will be seen. Sir, you are selecting the wrong option. Please kindly select, when you just follow step-by-step instructions now. When you click on share screen, click on share screen now. You see a lot of windows. The first top window is screen 1.
Okay, is it now?
Again, you have selected the wrong screen. The same problem will keep on happening throughout the presentation.
Okay, just a minute.
I would request you to just stop screen share. Now just follow step-by-step instructions.
Yes.
Just click on share screen. And then you see a lot of windows open. You have to select the first one जिसमें हमारे videos दिख रहे हैं आपको.
Okay.
Yeah. No, again you have selected the wrong one.
Okay.
नहीं आप स्टॉप स्क्रीन शेयर कीजिए, स्टॉप कीजिए स्क्रीन शेयरिंग। अभी आप एक एक करके फॉलो कीजिए। शेयर स्क्रीन पे क्लिक किया आपने नीचे, उसके बाद आपको क्या दिखता है? जस्ट टेल मी ओरली।
On the left side is our screen. Left side is our screen is
ऊपर
visible.
ऊपर देखिए स्क्रीन लिखा हुआ है, जो स्क्रीन लिखा हुआ है ना वो विंडो को सेलेक्ट कीजिए माउस से।
Yes, screen here.
हाँ उस पे डबल क्लिक कीजिए।
Yes, double click किया
अच्छा
है।
ठीक है, प्ले कीजिए, लेट्स सी व्हाट हैपेंस। दिस इज ओनली विल शो द पावरपॉइंट प्रेजेंटेशन, दिस विल अगेन आई डोंट नो वेदर इट विल शो द वीडियोस।
Okay, okay. Just I'm continue the PowerPoint presentation first, then we'll go to the video. Okay. Just let us complete the PowerPoint presentation. Okay. So this is the trainer bug gate. This is basically it's unstable gate, as the trunk is going side by side, and this is unstable gate. But the other is the stable gate. How to know the stable gate? Basically, the swing phase and the stance phase, it is basically it is a 40% is the swing phase and 60% the stance phase. But if the stance phase is very short, so in the along with the painful facial expression, so that is the 2 point which is diagnostic of the antalgic gait. Whereas in the short limb gait, it is a very stable gait, where the stance phase is absolutely, it is 60% and the swing phase is 40%. There is no painful facial expression, but there is some swaying of the shoulder only on the up and down, as it is not seen. It is an unstable gait, as I show you in a Trendelbach gait, whereas the trunk is showing side by side. Whereas in the short limb gait, trunk is going up and down. This is most important. This is not side by side. That is the way by which you can easily diagnose this stable. There is a short limb gait, whereas unstable is basically another name is the lurching. This is lurching, is unstable gait. Okay. Now inspection, I already told, is the attitude and deformity. Now it is asked, what is the deformity? Basically, deformity is the permanent deviation from the anatomical position. And the next is the swelling and the wasting. So swelling and wasting, we have to examine especially the muscle bulk. Where is muscle bulk? We have to see the wasting. But the swelling, there is maybe due to soft tissue collection or maybe abnormal swelling. So there are some normal low land around the joints. Suppose around the hip joints, you have to see the groin, which is the low land, and the wasting, you have to see you have to see the quadriceps. We have to see in the back, that is the hamstring, as also on the back of the buttock, that is basically the gluteus maximus. And also the skin abnormality, you have to see whether there is ulcer, sinus, scar. So these are three subheadings which is examined in the inspection. Now the palpation, so we have to see the local temperature and tenderness. Why the temperature is examined first? Because and with the help of the dorsum of the fingers, we have to see the temperature. First the normal side, then the abnormal side, then again the normal side. Because just after examination, when this once the examination started, the temperature may be abnormally increased. So temperature should be examined first. Next is the tenderness, of which we have to most important is the anterior hip point tenderness. Next is the palpation part. Palpation, we have to see the palpation of the bony part as well palpation of the soft tissue part. Next is the palpation of the skin abnormality, if any, like ulcer, sinus. How do you differentiate between the ulcer and sinus? This is a question asked in the examination. Ulcer is basically, it is a superficial excoriation of the skin, so it is completely, it should be mobile. It should not be fixed to the underlying structure apart from the subcutaneous tissue, but it is mobile little bit, irrespective of the contraction of the muscles or the bone. But sinus is always fixed to the underlying structure. It may be fixed to the muscle, where it is moved at right angle to the axis of the muscle, whereas for the bone, it is fixed in both axes. So it is easily understand. This is the palpatory counterpart of the ulcer and sinus. Now there are some local methods. It is given in the OSCE system, like the local temperature. What are the steps to be examined for the local temperature examination? Next is the identification of the anterosuperior spine. So there are some doubt, some especially during some, if it is a little bit higher up, it is a lower down. If it is normally it is higher up, that indicates what? That indicates it is a adduction deformity. Now if it is relatively lower down than its counterpart, it is usually abduction deformity. Now it is asked why it is if it is lower down, why it is called it is abduction deformity? Why if it is a higher up, why it is called it is a adduction deformity? Now how will you confirm it? How will you confirm whether it is a ASI, it is lower or higher up? So this is basically, it is a deformity. And the definition of deformity is what? That is the absence of the opposite movement. So if it is an anterosuperior spine, it's a lower one. So this is basically is an abduction deformity. This is abduction deformity. So adduction should be nil or it may be negative. So if we examine the movement, so you can easily understand whether it is with the movement it is moving or not. So if there is no adduction deformity, no adduction movement, and anterocerebellar spine appears to be lower down, so it is appears to be abduction deformity. But again, there is another way of ruling out. So that is the, we have to understand, we have to identify the ASIS, and after that, from the umbilicus, we have to draw a line to the symphysis pubis, and we have to join both the ASIS. We have to see the angle on both the sides. If the angle on both the sides is 90°, that indicates that it is anterocerebellar spine absolutely at a same level. But if it is at a different level, then we can draw a perpendicular to that line joining the umbilicus to the symphysis pubis, and that is the line, that is the angle which is formed between this line joining the ASIS to this vertical. It is the Coteries angle. So if in that case, so without moving the hip joint, if the hip joint is very much painful enough, so in that case, without moving the hip joint, we can easily understand, we can ascertain the exact amount of abduction or adduction deformity. Okay, now the GT, identification of GT, this is also another method which is examined. So how to identify symphysis pubis? Symphysis pubis is identified with this first, it is a classical methods from the umbilicus directly goes down to identify the symphysis pubis, and from the symphysis pubis going away from the inguinal ligament to identify the most prominent bony point on the lateral side is the anterocerebellar spine. Anterocerebellar spine going up along the iliac crest. It is the highest point of the iliac crest. Then going down again towards towards the thigh. The first bony point which is coming in the line of on the outer aspect of the thigh, it is the tip of the greater trochanter. So once the tip of the greater trochanter is identified, first we have to identify this position with the help of the three digital fingers. So that is the digital digital branch triangle or three digital palpation. So where the three fingers are kept. One, the thumb is on the ASIS. There is a middle finger is on the tip of the trochanter, and the index finger, it is the imaginary vertical line which is drawn from the anterocerebellar spine directed towards the bed. So this is these three digital point palpation. Another is the anterior point. it is the 1.25 centimeter below the mid inguinal point. Mid inguinal point is the midpoint between the anterocerebellar spine and the symphysis pubis. Now from that level, we have to go 1.15 centimeter below that midpoint of this mid inguinal point, and then we have to palpate the femoral arterial pulsation. We have to go on the lateral side of the femoral arterial pulsation, that is the anterior hip point. We have to press it one by one. First on the normal side, we have to see the face because it is an objective sign, and then we have to see the other side. Okay, now the GT. We have to, once the GT is palpated, we have to see see the tip, whether it's level, its surface, its tenderness. Tenderness, it is on the superficial GT tenderness. It is a deep GT tenderness and deep bitrochanteric tenderness. So superficial tenderness, it can be easily ascertained during the surface palpation. Surface of the GT can easily ascertained by just gentle rubbing over the greater trochanter. So, and in that case, if it is so it is highly tender, so superficial tenderness can be easily palpated. Next, once the border of the GT is ascertained with the help of the anterior border and the posterior border. Usually the posterior border is easily ascertained because it is covered by the muscular fibers of the gluteus maximus, whereas the anterior fibers is very difficult to identify because it is covered by the tough tensor fascia lata. So we have to give some little deeper part. So in that case, if the anterior posterior border is easily is identified, then you can easily identify the broadening of the greater trochanter, which is compared on the other side. And we have to push the trochanter towards the bed. That is a deep trochanteric tenderness, which is specially different from the bitrochanteric tenderness, where the bitrochanteric tenderness pressure is given from both the trochanter towards the center. So the force is transmitted from the trochanter up to the acetabulum. So any pathology from trochanter to acetabulum becomes positive during the bitrochanteric tenderness. Whereas once we push the trochanter towards the bed, so any trochanteric pathology will become positive. So this is the way of bitrochanteric tenderness. So next is the three digital palpation. I already told, once the GT is diagnosed, is a three digital palpation. These are the all methods usually asked in the examination. Next, the pulsation of the femoral artery is already told. Is the pulsation of the femoral artery is given, and what is the vascular sign of Nara? Basically, the femoral arterial pulsation is, if it is normally palpable, and it is equally and normally palpable vascular sign of NARAT is usually negative. So if it is difficult to palpate, so if the underlying the bone is absent, that is in case of there is dislocation, so it is very difficult to palpate. This is the way of this of the diagnosis, the positive vascular sign of NARAT. So some student says it is an absent pulsation. It is absolutely wrong. So in case of the absent the bony support underneath, so there will be difficult to palpate the femoral artery. So this is there is unequal pressure. So in that side, abnormal side, excessive pressure to be given from above to diagnose this to feel the pulsation of the femoral artery. This is the positive sign of positive vascular sign of NARAT. Another is we have to identify the medial joint length of the knee and the medial malleus. I will show in the video. And the distal pulsation, this is also be examined. So distal special pulsation, basically the popliteal artery, as also the arteria dorsalis pedis, and also the posterior tibial pulsation. This pulsation is also asked. These are the specific methods may be asked from the students. Now the movement examinations, always there are 3 points. We have to examine the normal side first, followed by the abnormal side. We have to see the active motion, then the passive motion, then the comparison. Comparison will always between the active and passive in different positions. Now, some special methods may be required, like the special maneuver is required. So for the passive motions, we have to see whether the movement starts from the neutral or the deformed position. We have to measure the existing range of motion, whereas the assert in the existing range of motion is associated with pain or not. This is most important. Suppose the flexion deformity, we have to do the Thomas test. So to see whether it is starting from the zero position or from deformed position. Next, measure the existing range of motion. Suppose a 30-degree flexion deformity, it is diagnosed by the Thomas test. Now existing range of motion is 30 to 100 degree. It is existing range of motion. Then you have to see this existing range of motion whether it is associated with pain or not. Because by this method we can easily diagnose 2 forms of disease. The one is synovitis and the arthritis. If the whole range is painless, but only the terminal portion is painful, that is known as the synovitis. Whereas the whole range is painful, whatever the range is present, that is arthritis. So this is the association of pain is so important. Now special maneuver is needed for the flexion, especially the unilateral or the bilateral cases. Unilateral cases for like if it is a flexion deformity of the hip, that may be due to flexion deformity of the hip or the knee. So in that case, how to determine whether this flexion, which is apparently visible, the limb is apparently visible in flexed in hip and knee, whether it is due to hip problem or the knee problem. So in that case, we have to do the bedside Thomas test. So we have to bring the limb outside the edge of the bed, so that we have to see if it is due to hip problem. So in that case, so it will present the deformity will persist. Whereas if it is due to knee problem, so hip is absolutely normal. So in that case, the thigh will immediately will touch the side of the bed. So it is very important. Okay. So this is the bedside Thomas test, and most important is a bilateral flexion deformity. So what are the different type methods by which we can is most important. This is most important is we have to test the Thomas test one by one, disregarding the other side. So this is the basic. This is the most important answer. Another is the bedside prone test. It is most important. This is the next one, especially for the child. We can do for it is very cumbersome for the adult, and also the supine position is in that case if it's a hip is very painful. So in that case, both the hip, both the lower limb keeping the knee straight is elevated from the bed. So once it is elevated, first we have to see the excessive lumbar lordosis. If the lumbar lordosis is present, that indicates there is a possibility of flexion deformity. But if it is a supine in supine position, it is very difficult to move the limb separately. So in that case, what will you do? Both the lower limbs keep extended in the hip and in the knee, and we have to elevate both the lower limb at a time to up to a point where the lumbar lordosis is obliterated. Then we gradually lower down one by one, and to see whether the lumbar lordosis is again reappeared, and that is the flexion deformity on that side. That is the supine position. Another is the abduction adduction deformity. It is seen in abduction in flexion, because that can help to diagnose the mechanical defect of the femoral head. And for the rotations, we have to see whether there is change of rotation occurs, keeping the hip in extended position or keeping the hip in flexed position, which is basically the basis of the sectorial sign, which is present if there is a mechanical defect of the femoral head. especially it is seen for the avascular necrosis and in another malunited femoral head or neck. So suppose this is the case, you can see here. So what is see, this is this one in the left side. This is seen, you can see here, is excessive internal rotation. Patient can sit like this. This is known as the sitting in television position. So it is excessive internal rotation, and see this is the external rotation is relatively restricted. So if there is a restricted external rotation at the cost of increased internal rotation, and see there is the adduction and the abduction is relatively normal. So basically this is from the examination of the range of motion, we can tell that there is excessive internal rotation at the cost of restricted internal external rotation, which is basically due to increased antiversion of the femoral head. So fair amount of range present but terminally painful, it is synovitis. Minimal amount of range present but whole range is painful, it is arthritis. All motion is symmetrically restricted and painful, it is basically it is from the arthritis. Okay, and the sum of the grossly restricted, some relatively unaffected, it is a mechanical form. It is a mechanical form. So this, as it is infected, in infection condition, all movements should be symmetrically restricted, or any infected or inflammatory condition. Whereas in the mechanical condition, suppose there is a coxa vera deformity, basically it is abduction and the internal rotation will be restricted, whereas the flexion will be relatively normal. So that is a mechanical problem. So in that case, some movements are grossly restricted, some movements are relatively unaffected. So by the pattern of involvement of the movement, we can easily diagnose the diseases like that. And the measurement, we have to see the apparent length, true length of the girth. This is the basic 3 steps. Apparent length should be examined from the fixed bony point, suprasternal notch, or from the xiphisternum, it's the upper point, but in the lower point, it is the medial malleolus. But the prerequisites is very, very important for examination. Prerequisites is basically we have to examine the patient in completely supine position, in a hard couch, whether the trunk should be straight and limb should be parallel in a well illuminated area. This is the prerequisites. And after that, we have to identify the suprasternal notch or the xiphisternum, and from the xiphisternum we have to identify the medial malleolus. It's in that position, that is the apparent length. And basically, what is the importance of the apparent length? Apparent length is the length which is visible after natural compensation. This is important for the patient's perspective, and but the true length is basically important for the surgeons or the clinician's perspective. So in that case, we have to actually correct the deformity. After that, we can ascertain the true length. So actual length is basically, true length basically is actual length that is excluding the natural compensation. So we have to exclude the natural compensation by the correction of the deformity. Then only we correct the true length. Next is the girth measurement. That is the maximum area of the muscle bulk. We have to ascertain on the normal side first, and in that case we have to mount, just point it down. And suppose in the upper third, in the femur of the normal side, it is the point which is the maximum muscle bulk is 10 centimeter from the anterospheric spine. And in that case, on the affected side, we have to examine on the same area, and on the affected side, the muscle bulk. And there are some special measurement, of which the most important is the Nielsen's line. In Nielsen's is a basic prerequisite, it's a basic position. The always starts, or in any test, first point is to take the consent of the patient, and also to understand the patient, what are going to be done. Next point is the position, exposure and the position. So next is the way, what is the position of the Nielsen's line examination? This is basically, it is a sideline position, and that the hip knee should be 90-90 flexed. This is most important. Hip knee should be 90-90 flexed. Otherwise, it is very difficult to identify. Next, we have to ascertain the anterospheric spine, then the tip of the greater trochanter, and the ischial tuberosity. Now, how will identify the ischial tuberosity? Now, ischial tuberosity is the most hard bony point if we go along the lateral to medial, along the gluteal fold. So from the gluteal fold, if you start from the gluteal from the lateral to medial, most prominent bony point on the medial most corner of the gluteal fold, it is the ischial tuberosity. So from ASIS, so there are 3 points: ASIS, tip of the greater trochanter, and also the ischial tuberosity. If we join these 3 points, if it is make a straight line, it is a normal. But if it is the trochanter is higher up, then that it will be at a higher level than the ASIS to GT. So this is most important. And more, what is the importance of the Nilsson line? Suppose there is a bilateral disease like bilateral avascular necrosis of the hip. So in that case, so this is most important. This is the most important line by which we can easily compare the what is the most affected part of the most affected hip. So in that case, we can easily balance the actually the length of the lower limb after the correction, after the operation. Another is the shoemaker's line. Shoemaker's line is the tip of the greater trochanter and the ASI, if it is joining and is going up, that is normally it will cut the umbilicus, or it will meet a point that is higher up to the umbilicus. But if the trochanter is higher up, then this line will join below the umbilicus. That indicates there is reduction of the proximal part of the proximal length of the femoral. That may be due to coxa vera, that may be due to intercapsular neck femur fracture. There are several other causes. So this is the shoemaker's line. But Nilsson's line is most important for the bilateral hip disease, where there we can easily compare, whereas because they're both the points, this ASIS and the greater trochanter, which is not related with the hip, whereas in the Brand's triangle is basically it is not reliable for bilateral cases as compared to Nilsson's line, because that is the 2 point, of which 1 point is it's on the affected part of the bone. So the Nilsson's line is more reliable than the Brand's triangle in case of bilateral affection. Now, suppose this is another OSCE I can discuss along with what are the steps of true length measurement. So again, see, these are the basic steps of true length measurement when we asked in your examination. First is to take the consent and explain the procedure. This is the adequate exposure of the both ASIS, knee, and the level of the heel from the side and the top. This is for inspection, so that we can identify the affected side. Next, we have to check the level of the ASIS in same level or not. Mark it. If not, it will square the pelvis and then mark it. Identify the medial knee joint line and then the mark it. Next, identify the tip of the medial malleolus and the mark it. Then the segmental length of the femur is ascertained from ASIS to medial knee joint line, that is supratrochanteric by the Brand's triangle, and the infratrochanteric by subtracting the base of the Brand's triangle from total length of the femur. And the tibial length is measured from the medial knee joint line to the tip of the medial malleolus. So these are the basic 6 steps which is asked in the examination, that may be in OSCE examination. Now, special test, basically of which the roll test is most important, because roll test is the test by which we can actually identify that which knee joint, which hip joint is affected. So it's a gentle rolling. Even the hip joint may be very painful. So this is the basic test by which we can easily ascertain which side is painful, much more painful. Just a simple keeping the in supine position. If we roll the hip joint, roll the whole of the limb, keeping the hip and knee extended, the patient will complain of pain or resistance. That is the roll test. But after that, there is basic prerequisites for the basic special test for the hip joint is the Trendelenburg test, which is the test of the power, basically the abductor muscles, L4, L5, S1 neurogenic segments. Lever arm is basically the femoral head neck, and the fulcrum is the hip joint. And the telescopic test for the adults, and for the child, it is the Burlow's test and the Ottolan's test, especially the stability test. And there is active straight leg rising. It is most important, active straight leg rising for the surgery, which indicates the structural integrity of the femur, quadriceps, especially the SI joint, and especially the active straight leg rising against resistance, which is basically the basis of the Steinfeld test. It increases the force, or increasing the loading force of the inside the hip joint. So if there's any disease of the hip joint, patient will complain of severe pain and resistance. So active straight leg rising is with or without resistance is another test. So Trendelenburg test, telescopic test, and these are the basic 3 tests must be done for any hip joint case. There are several other tests. I'm not going into detail. Often most important test is the Trendelenburg test. What are the prerequisites? So these are the prerequisites. See, this is the bilateral, that patient should be able to stand bipedally for at least 30 seconds. They have to understand the verbal comment. There must be some free abduction motion, because so to elevate the pelvis on the unsupported side, the other side of the standing side, there must be some abduction of the hip joint. But at the same time, there is no adduction, should not be any adduction deformity, because In adduction deformity, so in that case, the pelvis is always, it is a higher up. So in the affected side, if it is adduction deformity, there is no abduction, so it will not allow the pelvis to go up on the unsupported side. So free abduction and no adduction deformity is must for producing a normal tail work test. And normal coordination is most important. If the patient is not it is abnormal coordination, so it is very difficult to identify, elicit the tail work test. These are the prerequisites. Now, false positive is most important. So there are false positive, false negative tail work test. There are in the obesity. There are that is a free adduction. Is a see this always going to be positive. So the indirect tail work test, if it is very difficult, the patient is not able to stand. With that in the case, we have to identify this tail work test with the help of both. We have to support. We have to ask the patient to support his both the hands with the examiner's hand and elevate the limb one by one. So in that case, if the patient is very unstable, so in that case, once they elevate the normal limb, so the patient will give excessive pressure. Once he stands on the affected limb, there will be excessive pressure on the other side. That's on the normal side, because the normal limb is elevated off the ground. There is a possibility of falling on that side. So in that case, patient will give excessive pressure on that hand. So there are
Excuse me, sir.
several causes. I'm not going to detail. The Barlow's test. Just I'm going to finish now. So Barlow's test is basically Barlow's test. The autonomous Barlow's test is basically is a provocative test. Basically, it is how will you understand? How do you remember it? Is a Barlow means a Bahar law. Just we have to provoke it. We have to give, we just give them just simple like the telescopic test. We have to give jerk to make it outside the hip joint. It's a provocative test. Whereas autolani is the reducibility. The producer reducibility. So it is underlani. It is just on its almost, it is known as underlani. Just we have to give gradual abduction, so that is with the clink it will go inside it. So this is the this autolani's test. So examination of the proximal joint, distal joint is most important. Basically, for the three cardinal features, you have to see the deformity of the spine and also the tenderness of the sacroiliac joint, basically, and the movements. So the spinal movements we have to see. And the special test, we have to see the overt test. Piriformis test is the flexion and adduction, internotation test, and the Ludloff's test. These are the basic three tests we can do the other joints. And the examination of the last point, it is the examination of the always examine the gait as I examined it. And for the neurovascular reticular endothelial system, neurological examination for the hip joint, for the femoral nerve, we have to ask the patient to extend the knee, and for the sciatic nerve, we have to dorsiflex and plantar flex of the ankle joint. And for the vascular, I already told that the vascular pulsation should be examined. And the reticular endothelial system, we have to examine the Clockett's lymph node, which is present medial to the pulsation of the femoral artery, and also the external alia group of lymph nodes on the abdominal component. For the lower limbs, always have to examine the gait. For the hip examination, always ask for the parectal examination, and for the long case, always examine the other system. So that is complete the hip examination. So thank you. So we can ask the questions so that we can talk with the students.
Yeah, okay. Thank you, Professor Pal. I think there's done a great job in trying to cover a lot of things within the time. I know it's not so easy to include everything in the hip joint within half an hour, but we have some time for questions. So let's see how much we can do. I'm sure there'll be some things that you would want to get cleared about, things like Trendelenburg test and limb lengths and apparent shortening and true shortening, etc. So I think this is your time to ask these questions.
We have one question in the chat box, sir.
Yes.
Amit has asked how to grade socioeconomic status in history, and difference between limb and lurch. Are they same?
Yes, no. Actually, the limp is basically the abnormal gait. And the lurch is basically the unstable gait. Abnormal gait may be stable gait, it may be unstable gait. Okay, lurching is basically is a unstable gait, of which the Trendelenburg gait is the most important variety of the lurching. But not all the gaits are lurching. But as I already told, it is antalgic gait. Is shortening gait is absolutely stable gait, but it is not an unstable one. Unstable gait means the lurching. And socioeconomic status, it is not very difficult, because you have to ask how much is the social income, what is the amount, what is the knowledge of education. Basically, why it is important, because if it should be understandable. Your line of management or line of the counseling should be understandable for the patient. That is the why it is important.
So, Kumar Gautam has asked about posterior joint line. How to?
It is show. See, it is absolutely, it should not be told in the examination. There is no posterior joint line. The joint line is there's anterior joint line is most important. The hip joint is not exposed to the posterior. There is one point is present in the posterior part, that is the sciatic point. In some books, it is written in the it is a posterior joint line, but it is completely wrong. But there is a hip joint, because hip joint is not exposed to the posterior, it is exposed to the anterior. So there is no posterior joint line. That is the posterior joint line, which is fallaciously mentioned in some area. There is basically is a sciatic point. So in that, the sciatic point is the basically, if we join the PSIS and that is the ischial tuberosity in a line, and that is the junction between the medial 2/3 and the lower medial 2/3 and the lateral 1/3 point. That is basically the sciatic point, for under which the sciatic nerve passes. So that is basically the sciatic point. This is not a posterior point at
all. What is your view, sir?
About what? Are you asking me?
Yes,
yes,
sciatic.
Sir.
I have no view on
what
this.
Another, just
I agree, because I think these are when you see the hip, the pelvis, the hip is anteverted. Okay, so there is nothing that you can palpate the posterior margin of the hip outside. Okay, you can have a rough idea where the joint is, but you can't actually palpate the hip from the posterior aspect. Yeah.
Yes,
one question.
Yeah. Yes, which lymph node to examine and their significance, isn't it? Hello.
Yes, sir. Yeah.
Lymph node is basically they have to identify the draining lymph nodes of the hip joint. Our most constant draining lymph node of the hip joint is the external ilia group of lymph nodes. So it is if the abdomen is divided into 9 zones, of the most lower and outer zone is the iliac fossa. The right side is the right iliac fossa, left side is the left iliac fossa. So in that case, we have to how to test it. So we have to flex the knee joint. Why flex the knee joint? To relax the fascia lata, because fascia lata is attached to the inguinal ligament. If the inguinal ligament is relaxed, then the abdominal muscles which is attached to the inguinal ligament is also relaxed. Our idea is to relax the abdominal muscles. So by flexing the thigh, so once the muscle is relaxed, then in that case we have to ask the patient to deep inspiration and expiration. We have to insinute the hands during the expiration so that we have to palpate the retroperitoneal structures, basically the lymph nodes, which are basically the retroperitoneal structures. So we have to insinute the hands on the right iliac fossa to identify the lymph nodes. This is the most important. Another group of lymph nodes is the cloquet group of lymph nodes. This is the medial most component of the deep inguinal lymph nodes, which is present on the medial most compartment of the femoral sheath. That is the just medial to the pulsation of the femoral artery. I've already told how the pulsation of a femoral artery is palpated. So just if we palpate the medial to that, so in that case, you can easily palpate the cloquet lymph nodes if it is positive. Okay. And
so,
how to...
There are two questions, sir. Yes. One is how to square if there is bilateral affection of hip joint, one side abduction deformity and the other side adduction deformity. And second question is about a Stinchfield test.
Yes, I'm coming. So abduction. So why this question of squaring is there? So in that case, so if we have to identify, if we identify the true length, so we have to identify the deformity. We have to correct the deformity. So if it is abduction adduction deformity, in abduction deformity, the anticipation at a lower level, adduction deformity is anticipation at a higher level. So in that case, so if it's anticipation at a higher level means it's the adduction deformity. That means abduction is not possible. So in that case, if we adduct the limb, then it will come in the anticipal aspect as same level. So how do you confirm it? So in that case, and again, the line joining the umbilicus to symphysis pubis and the line joining the both the and ASIS, if this the angle between of these two sides is right angle, that means it is a it is square. Pelvis is square. Square means there are 4 points. So, but we are moving the 2 point. Where lies the other 2 point? This other loop 2 point is the posterior superior spine, which has remained always constant unless there is a significant trauma. Because so we didn't, that doesn't require anything to move on the posterior side. So we are moving the anterior 2 point either by abduction or adduction, so that both the anterior superior spine is coming into the same level. So the other posterior points will remain automatically at the same level. So it becomes a square. That is known as the square of the pelvis. Sometimes they ask the examiners, we are moving the 2 points. What are the other 2 points? These other 2 points is the PSIS, which is always in its same level. It doesn't make anything else unless it is disrupted. But it's very difficult to become disrupted unless there is some sacroiliac injury or like that. Okay, so there is nothing to do like that. So another question is, what is the other question?
About Stinch field test, sir.
Stinch field test, yes. It is the active straight leg rising test. There are 2 points. One is the active straight leg rising, and there is a passive straight leg rising. Passive straight leg rising is not associated with the hip pathology. It is related with the sciatic tension by the different causes, like the disc prolapse or like that. There are different causes. For the hip joint, so if we ask the patient to raise the limb from the bed, keeping the knee straight, that increases the load of the hip joint, and that same load can be further increased. So if we ask the patient to elevate this active straight leg rising against the resistance, where the examiner put the resistance on the anterior part of the thigh, and ask the patient to elevate against the examiner's resistance. So that is the Stinch field test, where the basis of the test is to increase the load of the affected joint. If the hip is affected, so if there's any inflammatory component of the hip joint, the patient will complain of severe pain and he will get resistant to do that. So that is the basis of this Stinch field test.
Okay. And sir, there are 2 or 3 doubts usually during the exam. First thing, sir, do you accept digital Brand's triangle or 3-finger test, we should say?
There is no digital Brand's triangle. It is any book. It is only 3-finger palpation. It is a 3-finger. This is a basic thing, because the Brand's triangle is a true length. So once we ascertain the exact base of the Brand's triangle, so we have to actually square the pelvis. But this 3 digital palpation is done is just a qualified. Just like the rough estimation. This is not a true estimation. So this is not an accurate estimation. So this is basically, cannot be a Brand's triangle, digital Brand's triangle. This is a 3-finger palpation of the 3-point palpation. Okay, this cannot be the digital Brand's triangle.
There is one more question, sir. Each ASIS is at different level. Should we comment on label of PSIS on inspection?
No, that I'm already told. PSIS, actually the dimple of Venus, that may present the PSIS. Somebody tell it maybe it represents the PSIS. Somebody tell it is the sacroiliac joint. It may be higher or middle component of the sacroiliac joint. So there is no question of there is comment on this PSIS, because nobody knows which one is which exactly point denotes the PSIS. And what is the significance? In most of the cases, the PSIS it is in constant position, so it is very difficult to comment this also. Okay, there is no need to comment on the PSIS.
Sir. And one more doubt about the Thomas test, sir, because few examiner say to insulinate the finger
in this manner or in this manner, isn't it? It like this or like this? Is it your question?
We've lost Janki.
Yes, is the position is like this or like this? Inside your finger like this, isn't it? Is it your question?
Yes, sir. How to insert the finger?
Like this or like this, isn't it?
Yes.
Yes, I got the point. Actually, what is the motto of doing this? So actually, there is hyper exaggeration of the lumbar lordosis, which is noticed by the appreciating the light on the other side. Once the patient lying on a hard couch, So that is the exaggeration of the lumbar lordosis. Our motto is to nullify the exaggerated component, not the whole component, isn't it? Exaggerated component should be removed. So in that case, if we keep like this, so there is a normal curvature of our finger. So the body will come earlier than this, or will touch earlier than this level, because there is a concavity. In this side there is a concavity. Okay, so it's better to put like this, in this manner. So in that case, only the exaggerated component will become nullified. But if we keep like this, as it is a concave one, so the body will come furthermore to touch on it. So in that case, the whole lumbar lordosis can be obliterated. But that is not our motto. Our motto is just to obliterate the exaggerated component of the lumbar lordosis. So that is why it is better to put the finger like this.
What is your view about this question, sir? Because this is few of the examiners are not accepting if it is, they say on both sides it is okay. Because this is little confusing, sir, and during the examination it is better if we can clear it.
So maybe you should ask the DNB board to make a rule on it. Because I mean, there will be independent examiners who will have their own ideas, unfortunately. Okay,
see, what is the doubt? What is the doubt is the
honestly,
doubt maybe suppose if it is a subtle flexion deformity, it is very difficult to understand. The student will not be able to catch it, whether it is a actual flexion deformity present or not. That is the doubt. Okay, if it is a significant flexion deformity, there this sort of question, this sort of doubt will not come, isn't it? So I'm giving the answer. If it is a doubt that there is a subtle flexion deformity present or not, so in that case, it's very easy to examine the extension. If that affected side doesn't have any extension, that indicates there is a possibility of flexion deformity, because by definition, deformity means that is a permanent deviation from the anatomical position. So if it is a permanently deviated from the extension, so extension will not be there, isn't it? So that is, if there is a very, very little amount of deformity, especially for the child, because in child there is a lot of elasticity. So simple, you make a patient the prone and examine for the extension. If the extension amount is almost same to the normal side, patient should be nullified. There is no flexion deformity. Okay.
Yes, sir. The last question, sir, from the chat box. Gautam has asked, while performing tunnel work gait, we observe from behind level of PSIS. Is it correct?
Yes, actually, the Tenelberg test, Tenelberg test is basically, it is an inspectopalpatory method. We have to inspect some area, palpate some area. What are the points to be inspected? There are actually the gluteal fold. Some books it is written gluteal fold. Somebody is written the dimple of Venus, and this is for the inspection. And some for the palpation, we have to put both the limbs, both of the hands on the highest point of the iliac crest, and the thumbs we can keep on this dimple of Venus. So we have to sit. We have to sit on the back of the patient. Patient will stand. The examiner will sit on the back of the patient. We have to identify. We have to keep both the hands on the highest point of the iliac crest, and we have thumb on the PSIS. We have to see the level of the buttock, whether it is going up or down, and ask the patient sequentially to elevate the limb, elevate the affected limb or the normal limb one by one. We have to see whether it is going up or down, and we'll see the pelvis also it is going down. So this is the answer.
So thank you, sir. Most of the thing we have covered.
Yes,
So,
thank you very much, Dr. Pal.
There'll
always be, so for the DNB, I think you have to have a clear method of examining. I think every now and then the examiner may not agree with you, but as long as you have a clear method of doing what you're doing, you should be able to justify it to him. Okay, hopefully with the OSCEs, you will not have that major issue of whether you put your hand this way or that way. In practical terms, does it really make a difference? It's very hard to say. Okay, so I mean, personally, I don't think one should go into these little minutiae, but I think there will be always some examiners who are very particular that you put it that way. If you have to choose between the two, I think what Dr. Pal said is probably the better way. So if you do it like that, you can justify it and say that this is the reason I'm doing it. Because if I put it the other way, maybe I will put it into not just correct the lumbar lordosis, may even cause a kyphosis in the thing if I bend it too much. So that's, but personally, I don't feel it's such a big deal as long as you do the thing carefully and you're feeling for the loss, obliteration of the lordosis. Okay, so I think have a method and give that to the examiner. If he doesn't agree with it, he'll say, I think this is better, but he's not going to penalize you if you're doing it in a proper step-by-step manner with a clear idea of what you're doing. Okay?
Thank you so much, sir.
Ananda, with your experience with the examinations, you agree with that?
Yes, now for the students, just I want to say, now the examination pattern is going to become changed. Actually, they have to answer all the questions of the OSCE, the number of six marks for each questions of 25 marks. So of 150 OSCE questions will be there, and there will be one virtual case and one physical case. So for the OSCE, what I want to give some tips for the students. So we have to always carefully read it properly, and because there are 2 or 3 questions, 2 or 3 slides of the same questions. One slide maybe may run for 1 minute, second slide maybe 2 minutes, and third slide maybe 1 minute. Total is 4 minutes. Within 4 minutes we have to answer 6 questions. So always read it carefully in a cool brain, but and then you write. And once the slide is over, you cannot repeat, you cannot see it again. So it is very difficult. If you miss the first slide, then the other 2 key will already become wrong. So we have to read it carefully, and you can keep some 1 or 2 question to white paper by the side, so that we can readily mark it what we are thinking about. So this is the tips I think you can use during your OSCE examination. And the key is very important. So hints, that there are some specific hints is given. So we have to always pick up that hint. So you have to write it. You have to ask the questions to each other, with your fellow students, with your seniors, and specifically very basic. Just I have given the example of this true length measurement. So these are the basic steps. Every step should be very, very important. So if you miss one step, then that means you may lose half points or 1 point like that. So it is very important.
Okay, so I think we should call it a day because it's already about 8:08. Thank you very much, Professor Pal.
Thank you, sir.
Thank you for taking out your valuable time and being here with us. And until, I think we have something tomorrow on the spine, isn't it?
Yeah, yes, sir. We will have some spines, Rajgopalan's registration. Okay. Thank you so much, sir.
Okay,
thank you, sir.
Sure.
Thank you very much.
Thank you, student. We'll meet again. Thank you.
Sure. Bye.
Yeah, sure. Thank you, sir.